Hi, good afternoon. It's 12:30. Welcome to another edition of Lunch and Learn. We are very pleased to have Dr. Nick Leung here today to talk to us about elbow pain. And he is stating that it's not always tennis elbow, although I find it to frequently be tennis elbow. So we'll see if he can prove me wrong. Nikki, if you can go to next slide. So we want to just remind folks that this is good. The category, CME category has changed since we started this to category 2. That's a self-reporting category, and you're welcome to report that to your medical associations. This is AMA PRA category 2, and you're welcome to click through this to get more information about the differences between the two. Next slide. And we want to tease the upcoming Lunch and Learns. We have next week, we're going to hear about compartment syndrome from our acting chair of emergency department, Dr. Irene Tien. We're excited about that. And then the following week, what you need to know is Dr. Glicksman's going to talk to us about sinus disease. Next slide. And then you guys have heard me talk about some wellness initiatives in the past. There's a new one I wanted to make sure you're aware of. These are virtual weekly sessions. They are free to you, guided meditation, virtual meditation, every Thursday from 5 to 5:30. So that is tonight. So feel free to hop on in and check that out. Also, if you have any questions about this, you can email Audrey Bossy. Her email address is on the bottom of the screen. Next slide. And then I'm going to step away and have Dr. Leung take over. Nikki, if you can make sure you unmute yourself and take your video camera on, and that'd be great.
Okay. Can you see and hear me now? Okay, John?
I can. It's perfect. Thank you.
Perfect. Great. Thanks so much, John. Thank you, Audrey. Thank you all for having me here and tuning in to listen a little bit about elbow pain. It is most of the time tennis elbow. You're exactly right. But I'll just tell you about a few other things besides tennis elbow that do sometimes cause pain. I'll show you a few cases of reflecting as such. Sadly and very unfortunately, I have no financial conflicts to disclose. We take care of a lot of different musculoskeletal problems here. I do, at least in the upper extremity. There are many causes of elbow pain. Some of the things I'm not talking about. I'm not talking about these causes of elbow pain. We're not talking about trauma today. The things that might cause a patient to show up in the ER. I do take care of a lot of children with elbow pain. I'm also not going to be talking about that today. So I'm really going to be focusing today on non-traumatic causes of adult elbow pain, which is, I think, judging by the names I see here in the audience, what most of us are seeing here. Okay. If anybody has any questions, feel free to leave me a question in the chat box or speak up, and I'll try to get to any questions that you may have at the end. I'm going to try to keep moving here just because we only have half an hour, and try not to avoid sounding like I'm making pressured speech here, but feel free to interrupt me if there's any burning questions. So when dealing with elbow pain, like on all of medicine, the history and physical examination is key. I always like to ask patients about the location, the duration, and mechanical symptoms are a big separator between the different categories of elbow pain. Patients with tendonitis, tennis elbow, for example, do not usually have mechanical symptoms, so it's always important to ask about that. What I mean by mechanical symptoms is things like clicking, popping, blockage of motion. I also like to get an idea of the severity of the pain, and that kind of helps me decide, what do I want to do with this patient? Do I want to do something more aggressively or just kind of give it more time? And I don't like to use like 1 to 10 scales. I don't think they're perfect, but I like to get in the patient's own words kind of what is going on with them. Is this pain happening at all waking hours of the day? Is it keeping them awake at night? These are signs of more significant pain. Or is it just kind of intermittent? They get through most of their day without the pain, and it only happens with very specific activities. That's a different category of patient. This is my arm, by the way, just to let you all know. That's what my arm looks like. Yeah. But when you're doing a physical examination of the patient, location is key. It's like they say in real estate. So just to point out where on the elbow you might find some of these pathologies, you've got lateral epicondyle being the site of tennis elbow, first and foremost. And these are all sites on the lateral elbow, the side that's facing us. If you've got a patient who's got pain a little farther posterior, it could be a number of other problems that are truly joint problems. So I would classify these as problems inside the joint. Things like arthritis or synovitis, which just means a non-specific joint inflammation. The rarely seen but often talked about in orthopedics, the plica, which is a thickened flap of tissue which is inside the joint. It's kind of akin to when you bite your own cheek and the the cheek is swollen, that can happen inside of a joint as well. Patients with pain in the front of the elbow may have a problem with the distal biceps. Pain in the back of the elbow, maybe from the triceps, or an early case of Electron bursitis, where they may not even have a real swelling of the elbow yet, but there is just pain there. Radial tunnel syndrome is an uncommon disorder, but is very often confused with tennis elbow. The difference being that the pain is going to be a little more distal on the elbow than at the bony epicondyle itself. And this is a disorder where there's compression of the radial nerve as it runs underneath the supinator and several other of the extensor muscles in the forearm. So, you know, in this time where many of us are doing virtual visits on telemedicine and Zoom, it's very helpful. One of the first things I'll ask the patient is use one finger and point to the site of the pain if you can. And that's really, really helpful. If the patient is able to do that for you, that gets you more than halfway to establishing your diagnosis. It's like I said, real estate is everything. If the patient can't localize it, they can't point with one finger, they have to use their whole hand to gesture where the pain is, then there's going to have to be a little more work on my part, a little more poking and prodding to try to figure out what exactly the diagnosis is. On the medial elbow, the patient may have pain over the medial epicondyle, golfer's elbow, or they may point a little more farther posteriorly, and that could be a case of cubital tunnel syndrome, which is a compression of the ulnar nerve behind the elbow. Yes, patients can have this and not have tingling or numbness in the fingers, as would be expected when you have a compression of a nerve. So here it is, just in summary, a list of, not even a complete list, but a lot of different causes of elbow pain that are not tennis elbow necessarily. That's a lot of stuff. I'm not going to go over every single one of those in full detail, but I'll try to expound a little bit more on each of them. I know this is not all about tennis elbow, but I will talk a bit more about tennis elbow because that is the most common things you all are going to see. When a patient has tennis elbow and they are actually in the office, I like to perform a couple of exam maneuvers. This one is known as Cozen's test, or just a resisted wrist extension test. And what I'm doing here is going to be stabilizing the patient's forearm, asking them to place their hand palm down and point their fingers at the ceiling. And while they're doing that, I'm going to pull down on their hand, making them use their wrist extensor muscles, which run along here and are attached at the lateral epicondyle. And this should reproduce quite a bit of pain at the lateral epicondyle in a patient who truly has tennis elbow. Simply flip their hand over so that it's palm up, and then this is called an armbar test. At least that's what I call it. I'm not sure if this otherwise has a formal name, but I'm essentially applying an armbar. This is my medical assistant, Grace. Her elbow is just really bendy. Don't worry, I'm not actually dislocating her elbow or doing anything like that, but I'm applying upward pressure on the back of the elbow. A patient with tennis elbow will not have that much pain when you do this, whereas a patient who has a plica or arthritis or synovitis will experience a lot more pain because of the impingement in the back of the elbow from this armbar. Palpation of the lateral epicondyle will cause pain. It's usually not going to be right on the bone, but just a tad distal and a tad anterior. That's going to be where the takeoff of the ECRB tendon is. Radial tunnel syndrome can be diagnosed by just palpating a little distal to the epicondyle, not here, but over here. And if you find this little palpable groove, what this groove represents is the divot that rests between the brachioradialis muscle and the common wrist extensors. In a patient who comes in complaining of medial elbow pain, most of the time that's going to be golfer's elbow, but not always. So I like to do these next couple of physical maneuvers. So this is a patient, with the golfer's elbow, once again, holding the elbow straight, steadying it with the forearm. I'm going to ask the patient to fully pronate and make a fist, meaning turning the hand palm down. Then with my other hand, I'm going to try to turn it back palm up so that the patient then has to use their wrist flexors and their pronator teres muscle, which is on the other side of the forearm. So I should have taken the photograph on the other side. But what will happen then is the patient will have significant reproduction of medial elbow pain because they're using those muscles, and that would suggest the presence of golfer's elbow. Palpation on the medial epicondyle would be tender. Again, it's not going to be right on the bone. It's going to be a little bit proximal, a little bit anterior, and a little bit distal. This is another stress test that can be performed, again, really just testing the ligaments. And this is just called a moving valgus stress test. That's testing the medial collateral ligament, which is in the same place as you would find golfer's elbow pain. But in this test, I'm fully passively externally rotating the shoulder, basically cranking the arm back behind, almost behind the patient's head, and then flexing and extending the elbow. And if they have a injury, inflammation of the ligament, this will cause pain, but generally a patient with true golfer's elbow will not have pain when you apply this maneuver to their elbow. Cubital tunnel syndrome gives you a pain in a slightly different spot. It's a medial elbow pain, but it's a little more posterior rather than anterior in golfer's elbow. And these two can be very easily confused with each other. A patient with pain in the front of the arm may have distal biceps tendonitis. This is a relatively common diagnosis. The distal biceps can be identified by having the patient flex the elbow to 90 degrees and supinate all the way so that their thumb is pointing up toward the ceiling. When that's done, the distal biceps really stands out, and you can really hook the biceps with a fingertip. You can even hang a coat hanger from it if you wanted to. But if you follow that cord, that biceps, as it courses down deep into the forearm, it'll end somewhere in here, and that's going to be where the patient has the most pain if they have biceps tendonitis. Okay, and of course, in the setting of an acute injury and a biceps rupture, which we see a lot of here as well, you won't even be able to feel the cord. It'll just feel like kind of a blob of mushiness when you can't identify anything that feels like a ropey structure in here. Triceps tendonitis or Electron bursitis is easy. You just palpate the back of the elbow, either on the tip of the bone or just proximal to the Electron, and that should elicit pain. When I'm working up causes of elbow pain, if their physical exam is pretty consistent with one of these soft tissue diagnoses, a tendonitis or a nerve compression syndrome, I'm not always necessarily going to get an X-ray. When I would get an X-ray or order an X-ray would be if a patient has mechanical symptoms. They have clicking, they have popping. That suggests that they might have some bony chips floating around in the elbow or bone spurs sticking out. Or in the setting of an acute trauma, you always want to make sure that there's not a fracture. So anybody who comes in reporting an obvious injury, elbow looks bruised and swollen, that's obviously going to get an X-ray as soon as you conveniently can. MRI is the best test to look at the soft tissues, but most patients who have a good classic physical exam for a tendonitis are not necessarily going to get an MRI. We usually are going to want to try to just institute the conservative treatment first, give it a try for about a month or two, and if the patient is still making no headway with their pain, well, then I would probably go ahead and request an MRI to confirm the diagnosis, see why the pain isn't getting better with reasonable treatment. Maybe it's the wrong diagnosis, but usually the physical exam doesn't lie. I would argue that a CT scan really should just be left up to the orthopedic surgeons. We usually use this tool as a measure of preoperative planning, pre-surgical planning. So somebody with complex fractures of the elbow or somebody with bone spurs all over the place on their x-rays and who we're contemplating surgery for, we may wish to get a CT to get a better three-dimensional appreciation of where all the little pieces are, so that we make sure we don't forget them when we are in surgery. This is an MRI of a patient with medial elbow pain. This is a coronal MRI. This is the medial elbow. This is a normal elbow. You can see a nice jet black structure here and another nice jet black structure forking away from it. And this would be the muscles on the medial elbow. And in this patient who has golfer's elbow, again, there is this nice jet black structure, and this is the medial ulnar collateral ligament. It's intact. This patient doesn't need Tommy John surgery. But here you can see the tendon torn away superficially to that and retracted. And you just see this filling defect that's filled with fluid. And they're not always going to look this dramatic. Many patients with golfer's elbow are just going to have pain, have an MRI that looks a lot like this, but there's just going to be a lot of white fluid within the tendon or even in the bone. This is a patient with a lateral elbow pain, and this is just to give you an idea what a dramatic looking tennis elbow looks like. And again, there's not this nice jet black structure reflective of where the tendon is as it inserts on the lateral epicondyle. Instead, it's torn, it's retracted, and there's fluid where the tendon should be. Again, they're not always going to be this dramatic. Most of the time, they're not going to be this dramatic. Most of the time, you'll see a nice black structure going all the way up, and there'll just be a little bit of whiteness in the tendon or in the bone. Most non-traumatic adult elbow pain, whether it's a tendonitis like golfer's elbow or tennis elbow, or whether it's an arthritis, or even mild nerve compressions like radial tunnel syndrome, most of them can be treated by these first three items. So if you know nothing else about elbow pain, if you got an adult who didn't have an acute injury, these three things most of the time are going to work. Heat is good. There's always this debate, heat versus ice, which do I do? Ice is good for trauma. So somebody comes in, the thing is bruised and swollen, or they've just had surgery. We usually recommend ice. Or post-workout pain. Patient's been lifting weights and now they're real sore afterwards. Ice is good for that kind of pain. Heat is good for this more non-traumatic pain, like from a tendonitis. Usually I'll recommend a patient who comes in first time for tennis elbow or golfer's elbow, put a heat pad on it, microwave it, put it on for 10 minutes, do that twice a day, keep it up for about a month. Most of the time that's going to help. You can use NSAIDs or over-the-counter Tylenol just on days where you're having particularly bad pain. Most physical therapists and occupational therapists are very facile at treating tendonitis around the elbow. And most patients will get better with 6 to 8 weeks of PT and OT, PT or OT. I'll touch on cortisone injections in a later slide. I don't underestimate the value of time when you're treating pain around the elbow. The natural history of most tendinitises in the elbow, and actually of most of the human body, is that the pain will eventually go away slowly, usually takes months. With tennis elbow in particular, roughly 80% of patients will have complete resolution of their pain within about a year. About 80% of patients will have resolution within about a year of the onset of symptoms. So we're talking sometimes a very long time. But if the patient is able to see that there is a light at the end of the tunnel, sometimes that changes their outlook and maybe they are more inclined to just adapt to it, wait it out, maybe modify their activities a little bit, and with the hope that it'll eventually go away. Now, in medicine, not everybody's the same. There are some patients, like the 20%, who have pain that lasts longer than a year, or patients who have really severe pain. It's keeping them awake at night. They may not want to wait that long. So sometimes those patients will come actively seeking treatment from you or me. The art of medicine consists of amusing the patient while nature cures the disease. And that is very true, especially of tendonitis of the elbow. Or to put it another way, as quoted in the House of God, I think this is rule number 13, the delivery of good medical care is to do as much nothing as possible. This is certainly not true of things like cancer or heart disease, but is very true of most non-traumatic elbow pains. These are exercises I lifted directly off of Epic. You can print these out on the patient's AVS when you want to look up some tennis elbow exercises for the patient. These are just called Mills stretches. And you can have the patient stretching their forearm wrist extensors and their wrist flexors for tennis elbow and golfer's elbow, respectively. I'll usually just ask the patient to do this 3 or 4 times a day and just for about a minute at a time. It's really not that hard to do. They can do it when they're sitting in a car at a red light or watching TV or on a phone call. Not that hard to just put their arm out and stretch it. Cortisone injections. These are very powerful. They are very good at relieving pain quickly and temporarily. They don't fix the problem. I look at cortisone injections like palliative care. It's not going to fix the patient's problem, but it will make them feel better for a while. It's a long while if you use triamcinolone and a shorter while if you use celestone or betamethasone, and somewhere in between if you're using depimedrol. There have been at least 10 placebo-controlled randomized trials to date in orthopedic literature and internal medicine literature and physiatry literature, all showing in general that when you evaluate a patient at 4 weeks, the patients receiving the steroid injections are better than patients receiving placebo in terms of pain scores. But generally by 6 months, this difference washes out and everybody's the same again. So once again, that's no surprise to any of us who give cortisone injections. There is no long-term benefit to giving a cortisone injection. And that's what I always express to patients. There is no long-term benefit. There is also a small risk of complications. The most common ones are going to be because we're injecting around an elbow and there may be sites where they don't have a lot of fat coverage, patients may experience depigmentation. This is a wrist that has de Quervain's tendonitis, and this is a picture taken about 6 months following the injection. This is completely harmless, but it, to some patients, is very cosmetic and unsightly, and some patients hate this. So I always warn them about that possibility. Now, this patient was not having any pain after their injection, but was disturbed by how the wrist looked. They waited it out, and generally by about 12 to 24 months after the injection, the skin reverts back to a normal color. A slightly more sinister complication would be if the deeper structures get degraded, and then you actually can have a rupture of the collateral ligament here, which inserts on the lateral epicondyle. Same thing can happen on the medial elbow when you're injecting golfer's elbow. In a lateral ligament rupture, this is a more dramatic example, will lead to this ligament detaching from the epicondyle, and that can give the patient a sense of feeling like the elbow is about to pop out when they try to straighten the arm. So this, unfortunately, is a complication which seldom gets better without surgery to reconstruct the ligament. So we try to avoid that as much as possible. This can happen up to 1% of the time in patients receiving cortisone injection for tennis elbow, and it's more likely in patients receiving many cortisone injections for the same tennis elbow. So for that reason, most of the time, most orthopedic surgeons I know will not offer any more than 3 injections. There are many surgical treatments for tennis elbow. This is just a depiction of arthroscopic treatment. This is the view of the inside of the joint, looking from medial to lateral. And this is the radial head, and this is the capitellum. And in this kind of surgery, I would insert a little thermal wand through this little portal and basically burn out and ablate this entire capsule and the overlying ECRB tendon. So it's basically treating it like it's a cancer. You're just cutting it out of the body and getting rid of it. And once that's done, you see the red ECRL muscle and the EDC, extensor digitorum communis tendon. And when you see that, the job is complete. An open surgery does the same thing, except you're coming from the other side of this wall. You're splitting the red from the white, and then you cut out this white part using a knife. There's also some interest more recently using 10X and other radio frequency ablative devices to come in here and do the same job by ablating this tissue in a more minimally invasive manner. So that's very interesting stuff. I don't do it, but I know there are some physiatrists in the area that do offer this. This is just a picture of what these incisions look like with an open tennis elbow surgery and with arthroscopic surgery. So there's some possible cosmetic benefit, but the results are not that much different. And they are also not by any means a guarantee. And so this is the reason why I'm very conservative when I offer tennis elbow surgery. It's really got to be a patient having a lot of suffering for a long, long time with no improvement with reasonable conservative treatment. Roughly 80 to 85% of patients, whether you're talking open surgery or arthroscopic surgery for tennis elbow, or golfer's elbow for that matter, are going to get better. And that means about up to 15 to 20% of patients don't get better. And that's very disappointing, obviously. So this is, I always inform patients of this and just let them know that, look, there is by far, this is far from a guaranteed surgery. This is not like carpal tunnel or trigger finger surgery where like 99% of patients are going to be better. But certainly for the patient who's suffering enough, these odds don't look that bad. Thankfully, the complication rates of tennis elbow and golfer's elbow surgery are low. Arthroscopic surgery may return them to work and sports a little faster, but it's still not really that fast. I still quote patients a minimum of 6 weeks before they're back to sports or heavy manual labor, even after arthroscopic surgery. I'm going to switch gears a little bit for the final few minutes here. This is a different kind of elbow pain. Like I said, sometimes patients will have mechanical symptoms. So you really want to think about diagnoses like arthritis, especially a patient who has a strong family history or a patient who's a heavy manual labor. It's not hard to understand how the patient is getting mechanical symptoms from this. The arthritis causes them to grow hypertrophic bone spurs that fill in these otherwise empty spaces. They start to grow loose bodies that float around the joint, and these can catch and cause clicking and pain when that happens. Treatment overall is much the same as for tennis elbow and golfer's elbow. Like I was saying before, heat, modification of activities, stretching, time. It's a little bit less likely that over time a patient with arthritis is just going to get better. But sometimes patients learn to adapt and change the way they use their arm and are able to cope with it rather than go on and have cortisone injections or surgery. Obviously, some patients will still end up in the boat of surgery. And these days, the standard treatment for a patient with arthritis of the elbow is arthroscopy rather than a joint replacement. It's a little bit different from patients with hip or knee arthritis. This is just a video depicting how this is done. This is the inside of an elbow joint. This is my little grasper. It looks gigantic, but the diameter of this tool is only about 3 millimeters. So it's just a short clip here. I fast forwarded it. That's why it looks a little shaky. Sorry about that. I hope I'm not giving anybody a headache. But you can see that little grasper is used to remove floating loose bodies. And we use this high-powered burr to shave out all this bone to reconstitute this concave surface on the front of the elbow so that they can flex and not hit the bone. This is the back of the elbow. I'm just using this device to push this loose body free and then grab it with this grasper. It truly is like playing a video game. And so here's a picture showing how this Electron tip can actually hit the roof of the Electron fossa when the patient tries to straighten the elbow. And so you can see how this bone hits that bone when the patient's trying to straighten. So that's very painful for the patient. So we knock off some of these bone spurs. And this is a osteotome, which is actually only about 1/4 inch wide, but it looks like it's a battle axe on this picture. It looks humongous. But anyway, we're just chipping off these little pieces of bone, knocking them loose, grabbing them with a grasper, clearing them out. We can use that burr again to clean up the rest of the bone that's above. This is just another part of the elbow. You can see how humongous these loose bodies can get. And again, it doesn't take a lot of imagination to see why the patient is going to feel better after all this stuff is removed. And it's also pretty amazing how some of these patients walk around with these huge things floating around in their elbow. Some of these patients, these are generally the happiest patients in my practice. They don't gain that much motion after these surgeries, but they gain significant improvements in pain. And usually it's very rapid onset pain relief. It's a durable procedure. The recurrence of bone spurs and recurrence or progression of pain in the future is generally pretty rare. A few patients are really going to be poor candidates for this. This is a patient with rheumatoid arthritis and very significant total joint disease. And this kind of a patient, just cleaning out bone spurs is not going to do it. They're going to have pain through the entire arc of motion. And for these patients, a total elbow replacement is generally going to be the most effective treatment. These are not nearly as robust as knee replacements and hip replacements. So I recommend this surgery extremely sparingly. Just for fun, this is a final case here. This is a 35-year-old woman who had many, many years of slowly, progressively worsening pain and loss of motion. So she has a rare disorder called synovial chondromatosis, which is a synovial proliferative disorder where bone spurs, not bone spurs, but loose bodies just start spontaneously appearing and multiplying in the joint. So during an arthroscopy, it's hard to even see because it's just like all these little asteroids floating around here. And it's not hard to remove these things with a grasper. It's like you could be closing your eyes and just stick your grasper in the joint and you'll come away with something. It's like playing that old game, Hungry, Hungry Hippos. After about an hour and a half of work, you can see these assorted pebbles that are lying around on the table. So to close, I just want to say, if you take nothing away from this, if you see a patient with non-traumatic adult elbow pain, just remember heat, stretching, activity modification, time. That's going to take care of most of patients. The ones that don't get better, I'm happy to see them. Patients who have a trauma and actual injury, that might be somebody I want to see sooner as well. And that's really it. These are the guys I work with. They're a good group of people. This is Newton-Wellesley Orthopedic Associates. There are 14 of us that together we take care of everything from head to toe, or neck to toe anyway. This is our number. This is our website. We have offices in Newton and Wellesley. We can take x-rays and we can apply casts and splints at all of our sites. So we can provide pretty comprehensive, immediate care for any patients who have urgent issues. We take care of a lot of kids. We usually get patients in the same day or the next day. And we also cover the emergency department. So for the true middle of the night emergencies, we will meet patients in the ER and we'll get them taken care of. And I hope I haven't run over time too much. I'll take
Perfect. Nikki, thanks so much. That was really great. I'm going to ask a quick question before we sign off. I don't see any other questions. I noticed you didn't mention the tennis elbow straps at all. You're not a believer, or what's the situation there?
No, so tennis elbow straps, believe it or not, have been studied in controlled trials as well and not been shown to be any better than patients not wearing straps. That being said, it's just a strap. It's only $10 at the pharmacy. So I don't discourage patients from wearing straps. I didn't mention it specifically, but yeah, I'm all for it. I would say if I had a tennis elbow, I would probably use it because what do you got to lose?
And do you have them modify any activities? Because I mean, I'm sure you don't get a lot of tennis players. These are all folks who are getting tennis elbow from usually job and other things, correct?
Yeah, that is true. Most people I see with tennis elbow don't actually play tennis. But if you think about the way the ECRB works, it's going to be more active when the patient has an overhanded grip. So as much as possible, one very simple modification is try lifting with an underhanded grip whenever you have to carry things. If you're lifting weights in the gym, that's still fine. If you got tennis elbow, go ahead, keep working out. Try to convert most of your activities to machine weights rather than free weights. It's a little harder in this day and age because fewer people are going to the gym. Most people don't have like a home setup like that. But if you are going to the gym and using free weights, try not to do free weights. Try to, for example, do your bench presses on the machine rather than using a free dumbbell.
Great, thanks.
Yeah.
So thanks so much. We'll be back next Thursday for our next talk on compartment syndrome. We also want to plug our Wednesday morning grand rounds, 8:30 a.m. Those are also by Zoom. Those links should come straight to your email box, and that's, of course, our great Department of Medicine. Any family docs or folks taking care of kids, pediatric grand rounds has started up again. That's Zoom, 7:30 a.m. on Wednesdays as well. If you're not getting those links and you'd like them, please either email myself or the department. Nikki, thanks so much for joining us and for enlightening us on elbow pain. Hope everyone has a great weekend, and we'll see you all next week. Bye.
Thanks a lot.
Sure.